Good morning. If I can hear or get some response on whether you all can hear me clearly.
Yes,
Right.
doctor.
So thank you for inviting us. My name is Dr. Mahaara Hussain, and I am a breast cancer surgeon at Mediclinic Wellcare Hospital. The reason we are doing this talk right now is because breast cancer has been increasing worldwide. And if you would look at this first slide that we've put up, 1 in 8 women will be diagnosed with breast cancer in their lifetimes. And this is data which is global data. It doesn't apply to developed countries or developing countries. It can be anywhere in the world, which means that at the end of this talk, someone we know, someone who knows someone we know, one of our colleagues, one of our contemporaries, perhaps one of us, will have something which could evolve into a breast cancer shortly. And I think this is the main drive that has been identified by governments, organizations, healthcare facilities worldwide, and why we have this thrust to create an awareness about the disease. What we are going to do in this talk is perhaps walk through what is normal for us so that if something abnormal comes up, we identify it before we actually approach a doctor. And the last two lines in red are perhaps the most important in this slide. If we pick up the disease early and we treat it well, there's a 98% survival rate. But if we pick it up late when the disease is advanced, despite advances in medical care, we still have a not very encouraging 27% survival rate. Now, 25% of ladies with breast cancer are less than 50 years of age. Dubai, the UAE, we have dynamic populations here. People come in here, they work, they earn money. There are more and more programs to settle people here in post-retirement. But as of right now, most people come here in their fertile, reproductive, active world age groups, and they come and they work and they go back home, which means quite a few of us out here who are in or around the age group of less than or around 50 years are at a risk for being that higher diaspora that can pick up breast cancer. Oftentimes, people ask us, why do we do mammograms? If in every 1,000 mammogram, only 2 or 4 of them will convincingly give you evidence of cancer, is it worth doing mammograms as a screening? And the answer is resoundingly yes, it is, because for those 2 to 4 people whom you have picked up the cancer in, you have had a chance to treat that cancer before it becomes advanced and aggressive, and you can actually give them quality of life which is equivalent to what they had before a cancer diagnosis. 70% of women with breast cancer have no identifiable causes. Now, this number I think will come down to about 60% as our genetic databases increase. But as a rule of thumb, we find that even if you take about 20 to 30% of women with genetic cases and 10% with certain medications or underlying conditions which can cause breast cancer, there's a very large percentage, more than 50%, where there is no identifiable risk cause. So what we can do is assume we are in that category and then keep checking ourselves regularly to see if something new is coming up. Breastfeeding protects against breast cancer, provided you breastfeed for a year or more. For those people who can't breastfeed directly, we tell them pump the milk. For those who can't pump the milk, as much as you can, you feed. And if you can't feed, well, keep yourself checked regularly. These are interesting slides, and we'll just go over them very quickly. Cancer is the third leading cause of death. It's actually creeping up. It's now reaching the second place because accidents seem to be going down, and that's not a very good idea, but that's where we are, that the cancers are creeping up. Arab nationals, all Arabs, including those in the UAE, both sides of the Red Sea, even the Persian Gulf, tend to develop cancers at least 10 years younger than their Western counterparts. And now we know because in large populations, we have genetic mutations which seem to be more prevalent in the Arab diaspora. Now, the last part is something I'd like to share with you. Between 1998 to 2002, there was a study done by the Ministry of Health. Now, in those days, for those of us who were here in Dubai, you will remember that if there was a breast cancer that was diagnosed or you had any lump, you moved abroad to get evaluated. If you had an employee who had a lump in the breast and suspicious changes, their visa was cancelled, they were paid termination fees, and they were sent back. If you had a subordinate or help in your house who had a tumor in the breast, most definitely they would tell you, I'd like to go back to my home country and get treated, and you'd send them back. So there weren't too many people being treated here. And what this study did was it made very, very generous provisions to include this drainage of the denominator, of the numbers we didn't know. So they really expanded they expanded their collection of numbers, and at the end we found there were about 140 cases of breast cancer within 4 years. Cut to 20 years later, not very long, just 20 years later, 2022, we are at the end of the COVID wave. Omicron had devastated everybody. The numbers in the UAE had contracted. We were still limping and recovering from where we were. And at that point, we did a very small review. We decided to just check and see how many patients there are with breast cancer in just two of the main hospitals we deal with. That is Mediclinic Wellcare Hospital and Mediclinic City Hospital. We didn't count Parkview, which is another large hospital in our group. We didn't count Mediclinic Abu Dhabi or Al Ain. We definitely didn't count our peripheral 16 clinics who drained to Mediclinic Wellcare and City Hospital. We just took two hospitals. And in 1 year, we found we had 165 cases. So you can see this 20 years ago, the whole of the UAE with expanded numbers, very generous provisions, 140 cases. And 20 years later, in just one private hospital, two group setups, City and Wellcare, 165 cases. Now, if to this 165, we included all the other Mediclinic hospitals, supposing we included the other private hospitals, American, Clemenceau, Fakir University Hospital, Medcare, Meteor, Aster, and then supposing we expanded it further, we included even the government hospitals, Rashid, Latifa, Al Baraha, Kuwaiti, Qasimi. And supposing we took it even further, we included hospitals across other states, Sheikh Shabut, Cleveland Clinic, other places, Burjil. Can you imagine how the numbers will be? And this explosion is what has gotten us worried right now and why we are so wary about dealing with breast cancers. I'm sorry, my phones are going off a little crazy at the moment. What are our risk factors for breast cancer? Females more than male patients. However, if there's a male patient who has a mass in the breast, or if there's a male patient who has a sudden ulceration in the breast, a wound in the breast without preceding injury, or has bloody nipple discharge, then I think they need to be regarded as equally high risk as the female patients. Age above 40 years is an independent risk factor. Now, our risk for breast cancer goes up. It goes up from the point we are born to the point we die. So an 80-year-old will perhaps have an 80% risk of breast cancer. It doesn't mean we're going to do something about that cancer. It simply means we have to identify that they may have something in the breast which will need to be tackled even at that age. But this graph is not a steady increase. After 40, there's a sharp spike that takes place, which is why most of our screening programs, including mammograms, start after 40 in a more acute, concentrated manner. If you have had a cancer, breast or otherwise, or you have family history of breast cancer, we have increased risk for you compared to the general population. For someone who gets their period early, that's early age of menarche, and finishes their period late, that means late age of menopause. For example, if someone gets her period for the first time at 12 years of age and finishes her period at 55 years of age, then her risk is slightly more than someone who gets her period for the first time, say at 14 or 15 years of age, and finishes at about 40 or 50 years of age. The longer the duration of your fertile period, the longer the duration of options of chances of changes going from normal to abnormal and abnormal moving to a tumor in your breast. For those people who have never had children or had the first child after 30 years of age, and this is actually a worrying trend because we find that the quality of the ovaries and the eggs that are released from the ovaries are going down. We live in a very, very stressful age at the moment. Perhaps we don't get enough of rest. Perhaps we have hormonal imbalances. Many people have polycystic ovaries. Many are on medicines which can suppress the ovaries. Something as simple or innocuous as Roaccutane taken for refractory acne on the face can have a long-lasting effect. And because of these reasons, we say that it's preferable to have the first child before 30 years of age, if possible. What can we do? We detect the disease early. Remember the first slide that was in red? If we pick up the disease early, 98% survival. And that's what we're looking at. The way of detecting this early is one, the breast self-examination. You check yourself. Two is you go to a doctor and you get evaluated. That's a clinical examination. And three is you get imaging done. Imaging most commonly is mammogram, but it can also be an ultrasound. It could be an MRI if the doctor sees fit. If there is nipple discharge, they could send the secretions for testing in a cytology, etc., etc. What we are going to concentrate on right now in this talk is the breast self-examination. Now, the idea of doing it is at regular intervals. We have to do it on a consistent manner. Like you fix up your appointment with the salon, like you fix up an appointment with meeting your friends, like you fix up an appointment perhaps in some other place, you have to fix up a date for yourself when you're going to examine yourself and regularly examine yourself on that same date. For those who do get their periods, if you have a 7-day cycle, which means day 1 is the first day of your period, day 7 is the last day of your period, check yourself about 3 days after it's over on day 10. But for those who have shorter cycles, say of 3 or 4 days, then day 7 seems a good time to check yourself. If you're going to see yourself when you're in your periods or just before you've started menstruating, the breast is going to be very sore, tender, and lumpy, and we're probably going to feel lump when none exists. So the best time is 7 to 10 days after the period, if day 1 being the first day of the period. For those who no longer get their periods, fix one day of the month and do it on the same day of every month. And for those who are breastfeeding or lactating, empty out the milk before you examine yourself. Milk tends to clog in the ducts at times, and this can be like a wave and you may not be able to palpate. So empty out the milk's ducts, dry out the breast, and then examine yourself. Examination has to be done in relative privacy. You can't do this in the changing room of, say, a mall or a movie theater or a restaurant or things like that. You need time and you need privacy to do it. We need a mirror where you can expose yourself and see yourself from your chin down to your navel. Why do we give such a vast area to be exposed? Because some people have heavy, large, pendulous breasts that hang. So if the lump is in the inferior aspect of the breast and they don't pick up their breast, they may not see the mass. Sometimes some masses in the breast, especially in those who have smaller size breasts, may not be in the breast. It may be below the collarbone or the clavicle. So if you will not get yourself thoroughly examined by yourself, you're not going to see it. And the best way is to visualize first what's going on. Look for symmetry on both sides. One breast tends to be a little larger or smaller than the other, and it can be on either side, right or left, that doesn't matter. But if you see that one breast appears substantially smaller or larger than the other, if one breast is pulled up or the other is hanging down, then there could well be something in that one breast pulling the lump up, or there could be something in the lower aspect of the other breast pulling the breast down. So identify it before you start touching and seeing what's going on. Look for redness of the skin. It could just be irritation to the undergarments. It could be a reaction to the prosthetic bra you're wearing, or it could be a rash or an allergy called eczema, or it could be a precancerous disease called Paget's, which very closely mimics allergies. So look for redness, look for dimpling, look for wrinkling of the skin when you examine yourself first. Look for visible bumps, especially in those who have smaller breasts. Sometimes the lumps are seen through the mirror itself when you examine yourself. Look for crusting on the nipple. These are like scabs that can form at times. Scabs typically tend to be something we have to evaluate. If you find that there is a crusting or a scabbing on the nipple, please go immediately to the doctor for a checkup. After you've examined yourself, raise both your arms overhead. Both the breasts should rise evenly. And this comes back to the point I was discussing in the previous slide. If one breast is not moving as much as the other, it's possible there's something inside the breast holding it back. And when you raise your hands above your breast, the lower aspect of the breast is seen better, especially in those who have larger breasts. And you can actually see that area, which you may not see when your hands are down. So examine yourself in front of a mirror with your arms by the side, and then after you've raised your hands above your head. The fingertips are not the right things to use because right now we use our fingertips for everything, for typing on a keypad, for sending messages, for picking up stuff. And the flat of the palm is also very calloused and thick. So the best way to examine yourself is use the flat of the fingers. We've highlighted this in the slide. That's the part of the fingers that needs to be used when you are checking yourself. Use the pads of your fingers and examine your breasts. And when you're feeling your breasts, you have to examine yourself in either a clockwise or an anti-clockwise manner. So if 12 is up, 6 is down, 3 is on the inner aspect, and 9 is on the outer aspect, examine yourself either from 12, 1, 2, 3, 4, 5, 6, or move backwards from 6, 5, 4, 3, 2, 1, and then go back to 12 and do the same on the other side. But examine yourself in an orderly, symmetrical manner. Don't do 12, 9, 8, 7, 6, because then you'll skip quadrants, you'll skip parts of the breast. So examine your breast with the flat of your fingers going in either the clockwise or the counterclockwise direction. Our textbooks describe lumps as marble in a bag of rice. I have never to date, in I think over 20 years of career practice, had anybody coming and telling me this. What people will come and tell you is, I feel a lump, I feel a bump, I feel a pee, I don't know, I feel something that's moving around. I'm not sure if I'm feeling something. Irrespective, if you feel something, get it checked. It may well be benign. It could just be a regular cyst or a clump of breast tissue. But get yourself sorted so you're reassured and you know what's going on in there. Your right breast has to be examined with your left hand, and your left breast has to be examined with the right hand. So you have to use the opposite hand to examine the breast. This is because after you're going to finish examining the breast, you're going to move your hand to your armpit. And you can't use the same hand on the side to examine the armpit. You can't fold your hand back that way. Our elbows don't work in that direction. When we start examining, always first press superficially and then press in deeper. When you press superficially, you will feel masses in the skin and the fat below the skin. When you press deeper, you will feel masses which are actually within the breast tissue itself. And like I said, we either grow in a clockwise or an anti-clockwise manner. After finishing the breast, we move to the armpit. A part of the breast actually grows in an oblong fashion into the armpit. And some of us will find that this little fleshy tissue in the armpit grows during pregnancy or after breastfeeding. That's because the milk ducts actually originate from the outer aspect and come inside. So they are fleshy and they can enlarge at any point in a person's life. So after finishing the breast examination, you must examine the armpits as well. In the armpit, it's the same thing. First examine yourself superficially and then deep. In this case, the superficial masses that you will feel will be that large bit of the breast tissue that we showed here. And the deeper masses you feel will be lymph nodes. Lymph nodes are like police chaos along a highway. They are periodically placed at various parts in our body, and they're meant to stop and pick up infections, bacteria. Sometimes for those of us who use powders or deodorants and the talc permeates through the skin, it picks up that calcium and it stops it there. Lymph nodes can enlarge if there is a tumor that's deposited there. Lymph nodes can enlarge with every period cycle, which is why some ladies have pain in the armpit. Lymph nodes can even enlarge if you have a small infection in the hair there or after an episode of laser ablation of hair or after waxing. Irrespective, feel it. If it's there, get it checked and be reassured whether it's normal or abnormal for you. And only after you have finished examining the breast and the armpit, come and squeeze the nipple to see if there is any secretion. We don't start with squeezing the nipple at the beginning of the examination. And this is because, I'm going to go back to the slide, the milk ducts start from the outermost aspect and then they come to the center. So if you have not massaged and you have not emptied out the ducts entirely, and you have chosen to squeeze the nipple, if there is milk or a secretion stuck in the outer aspect of the breast, you may not have milked it or drained it down to the center. So the first step is evaluate the breast in circular motions to mobilize fluid to the center. Then you evaluate the armpits to mobilize any secretions from there back down towards the center. And finally, you squeeze the nipple. Clear fluid, greenish fluid, purplish fluid, these are normal secretions, physiological. Ideally, they should not be there. But once our hormonal evaluation is done, a checkup is done, and it's confirmed that there is nothing happening there, we can leave this alone. If you have bloody red discharge or brownish discharge, which suggests old dried blood in the duct, that is something worrisome. It needs to be evaluated ASAP. Know your risk. Talk to your family members. It will be remarkable how much history comes out when you just talk to them. We think we know about members, but we may not know about everybody. For the breast, you need to talk to your parents, your siblings, the offsprings of your siblings, if they have any, your parents, brothers and sisters, and their offsprings, and the grandparents. So we go to parent, grandparent, children of the parent, brothers and sisters of the parents, their children, and if the grandparents have siblings also. That's the extended family tree we need when we're talking in terms of breast cancer. Get yourself evaluated with a healthcare provider. You don't necessarily have to come to a breast cancer surgeon. Whoever is evaluating you, your family medicine doctor, your gynecologist, anybody you're comfortable with, get yourself checked. The doctor will examine you and tell you what is the right test for you. If you're 40 and above, we start with mammogram and then add it up with an ultrasound. If you have family history of breast cancer, guidelines recommend we start at 35 with mammogram every 2 years and annual ultrasounds. If you have any other comorbidities, you've had other hormonal imbalances, you've taken treatment for fertility, you've had other surgeries done, you've had endometriosis, then perhaps we start screening even earlier, as young as in our 20s for people. Know what is normal for you so that you will know what is abnormal for you. And if you're not sure what's going on, then please meet your healthcare provider so he or she can reassure you with what is normal for you. Just a few things to cover up, and we are on the last few parts of our slides now, after which we can take questions if any. Warning things to look for are if you suddenly feel a hard lump or a knot or just thickening of the skin, your breast doesn't feel right or doesn't look right, get yourself checked. Sometimes masses haven't clumped together to form a lump, but they've already started causing a thickening in the overlying skin, and that is picked up by people. And it's remarkable because that's the stage you've picked up before something much happens if you come to us early. Look for changes in this texture, look for changes in the shape, look for warmth, redness, look for sudden pulling in of the skin in the form of a dimpling or retraction, look for a sudden outpouching if you can visualize a lump, look for scaly rashes or crustaceans on the nipple or other parts of the breast. See whether one nipple suddenly appears to be pulled in compared to the other side. If there's a sudden nipple discharge which appears, it may not be all that while you're having a bath you're seeing it, but you may see a stain on the inner aspect of your brassiere. Look for it. If there's a new pain that comes up in a new spot in the breast and is not going away and you don't think it's a muscle spasm, you lose nothing. Just get a checkup done with a doctor who can check and tell you whether it's just a spasm or something else. Maintain healthy weight. We know obesity is an independent risk factor for breast cancer. So try to maintain a healthy weight. Try to eat healthy. Smoking causes breast cancer. I wish there was any other way to say it, but there isn't. And this includes smoking, vaping, up to and including certain time high-risk nicotine gums. So try to avoid any form of nicotine intake as far as possible, up to and including shishas and non-nicotine shishas. Limit alcohol intake because alcohol has been known to act on the liver to cause hormonal imbalances in an indirect pathway as well. If there is postmenopausal hormonal use, limit it, talk to your gynecologist, have a concerned discussion, and they will tell you what is best for you. For certain people who are high risk because of family history, we actively tell them not to take certain variants of HRT, hormone replacement therapy. So do have that conversation if you're considering to take HRT with your gynecologist. Breastfeed if you can. If you can't, breast pump. If you can't do that, then get yourself checked regularly and check yourself regularly. Some myths and some facts. Healthy breasts, cancer-free breasts are not lumpy. Not true. Lumpy texture is de novo, natural texture of the breast. Breasts are lumpier before their periods. Some people have lumpier breasts even when they're ovulating in the middle of the cycle, which is absolutely okay. That's not a cancer to be worried about. If you bruise yourself, if you bump yourself, if you're playing basketball and the ball hits you on your chest and you have a hard woody lump, it's going to become a cancer. No, it's not. It may cause fat necrosis. That may be a hard lump that may persist. Once the doctors check you and they do imaging is classical for fat necrosis. You can leave it alone for the rest of your life. That is not going to become a cancer. Antiperspirants and deodorants cause breast cancer. Not true. But what we advise people is, as far as possible, use roll-ons rather than sprays. Sprays have formaldehyde, which can deposit on the skin and form formic acid. If that spray goes into the eye, it can cause posterior chamber cataracts. So preferably avoid sprays. Use roll-on deodorants if you have to. And as far as possible, try to use alcohol-free, aluminum-free deodorants. The aluminium precipitates on the skin and can cause some calcifications, which may interfere at times with mammograms. So it's preferable to use an alcohol-free, aluminum-free deodorant whenever possible. Having breast cancer will spread to cancer to other parts of your body or someone else's body. Well, your body, it may spread if it is metastasis. It will not spread to your partner. This is not an infectious disease. This is not cold, cough, flu, fever. It is not going to spread to anybody else who's your caregiver or in your surrounding areas. If a woman is diagnosed with breast cancer when she's pregnant, her baby will get cancer. No, alhamdulillah, the human body has been made in such a way that the placenta actually traps the cancer cells. And we've had many a patient who've come in with breast cancer, who have gone on to deliver their children, healthy children with no evidence of any disease in them. Facts, when it comes to breast cancer, size doesn't matter. Very true. A large breast is equally at risk as a small breast. What may happen is that in a small breast, the person may feel the cancer earlier than someone with a larger breast, but the possibility, the incidence of a cancer happening is the same in both the breasts. Screening tests help ladies detect cancer early. Definitely, yes. That's why we have these talks. That's why we have these programs. That is why in October, you'll find us everywhere. Social media, newspapers, television reports, screens, everywhere. But this is just 1 month. We'd like the screenings to be done throughout the year for women, as and when they feel, because cancer doesn't wait to wake up in October or any other month as a specific date. Breast cancer is easier to treat if you detect it early, definitively. And it's also that for breast cancer now, we have excellent adjuvant therapy, whether chemotherapy, whether radiotherapy, whether adjuvant immunotherapy, to augment and complement surgeries that we do. And our results are far better than some cancers, like say cancers of the pancreas or the gallbladder, where we still have rather dismal prognosis and long-term results. Breast has curative intent. So definitively, it is easier to treat if you can pick it up earlier. I think we've gone over this about 10 times right now in my talk, so I won't read the slide out for you all. If you do feel something in your breast, don't panic. 90% of the time, the lumps are benign physiological lumps. They may have been there. It's coincidental. You've just seen it right now. But if you're not sure what's going on, or if it's the first time you're feeling it, or if you're feeling a lump which has been there but now feels different, larger, firmer, softer, painful, textural change, color change, meet a doctor, meet a qualified physician who can see it, evaluate you, and then reassure you about what is happening in that mass. And that's the last slide. Thank you.
Thanks a lot, Dr. Mahaara. It's always a pleasure to have you speak on the subject. Shall we move on to the questions now? Okay. So I'll go through the questions. The first question, doctor, that we have here is, what type of doctor do we book with for a clinical breast exam?
So, family medicine doctors who deal with the breast, gynecologists who deal with the breast, or a breast surgeon. You're welcome to coming to us, to any of us. At WellCare, we have a setup which we have organized. If you get an appointment with me, you're very welcome to coming in. Otherwise, at the first line screening, we have doctors who have been appointed, who are trained, who deal with these things. We have protocols in place. So if you could just call up the call center, or if you get in touch with Sharanya, who's arranged this talk for us. Thank you, Sharanya. She's right now offline. You can ask her and we will organize it for you. We have family meds who do the baseline evaluation and then refer you to me to be evaluated.
Great. Thanks for sharing that, doctor. The next question, this woman would like to know if somebody has done breast surgery and they've put silicons, how can she self-examine at home?
She can still examine. It's based on where the implant was placed. Was it below the muscle or above the muscle? That's one of the things that we have to look at. Secondly, if she has scar tissue, when she meets the doctor will explain to her what is scar tissue and what is her breast cancer, her breast parenchyma. Implants are put not just to replace the breast tissue, they often put to augment, to increase the breast tissue. So the breast actually gets pushed up at time and it's easier to examine with an implant. But like I said, it depends on where the implant is placed.
All right. The next one is finding lumps that are slightly painful under the armpit closer to the menstrual cycle and they disappear after the cycle. Is that normal?
Completely normal. It's hormonal change. It's reactive lymph nodes in the armpit. Don't worry about it.
Okay. Does the type or fit of the bra affect breast tissue health?
No. I wish there was a better answer for this, but the answer is no. The only recommendation I have is that at night, don't wear a bra. Let the breast breathe naturally. Daytime, you can wear any bra of your choice. Wear a well-fitting bra. Don't wear a smaller size. Wear a push-up bra if you want to look a little augmented. Don't wear a smaller size and squeeze the bra and then cause pain and rashes in the armpit or under the breast. So wear a regular bra, any bra of your size that fits you well. At night, preferably, don't wear a bra. Let the breast breathe naturally.
So even if, women are wearing bras with underwire, it doesn't really affect,
No,
doesn't
no.
really matter. Oh, great. Good to know that. Okay, the next one is one screening enough to detect anything related to breast cancer, or do you have to complete multiple screenings at a go?
No, screening normally is mammogram plus minus ultrasound based on what is seen. So screening has it's the term screening typically has a triple assessment. The doctor examines you, gets imaging done. If there's any secretion, he or she sends that secretion for testing. Now the imaging may be ultrasound, maybe mammogram, maybe a combination of both. If nothing is picked up, they'll call you back a year or two later based on what they find in your history. If something is picked up, then they will evaluate it further. Do you need a biopsy? Don't you need a biopsy? Like the lady who's had the implants, maybe they will ask for an MRI to be done for that person. But that's based on what you find. At the baseline, all you need is ultrasound and or mammogram.
Okay. Do we need to do mammogram screening every year for women aged 40 years old and above?
If there is family history, if you have comorbidities, if you have hormonal imbalances, if you are on something like a Mirena loop, if you've had surgery in the breast in the past, then, or if you're on certain medications, then yes, otherwise mammogram can be once every 2 years. Clinical check with ultrasound, ideally, I would like it to say it should be done every year because ultrasound has no radiation whatsoever. Mammogram once every 2 years. And I understand there was a question I saw about the radiation exposure for mammogram that came out. There is far more radiation with a plain CT without contrast than a mammogram. If someone were to do a mammogram every year from the age of 30 to the age of 80, which means for 50 years, if someone were to do a mammogram every year on year without fail, the cumulative risk of that radiation causing a problem in that person's body is less than 0.8%. That means less than even 1%. There is far more radiation when we go under radiation towers of cell phones, etc., when we cross them and we are flying in planes. But those are things we have to do, we can't avoid it. This, I think, unfortunately, has been given a bad rep. It's not true. So mammograms, when done annually too, now we have digital mammograms, we have 3D mammos. They're extremely safe and they can be done. If you don't have a high risk history in your personal self or your family, then it can be done once every 2 years for you.
Okay. The next question, doctor. Does a contraceptive patch enlarge or advance growth of breast lumps? If yes, what would you suggest to ladies who use it to regularize menstrual periods?
So this is an interesting question. The breast size increases with any kind of hormonal manipulation. Any kind of manipulation. It doesn't matter whether it's a patch, it's an subdermal implant, it's an IUCD, a uterine device, whether it's a tablet, whether it's an injection taken at 3 months. There is pain and there is engorgement that happens in the breast because the breast has large amount of estrogen and progesterone receptors that respond to these hormones that we are giving it. What you can do is see why you're being given and deal with the root cause. For those people who have endometriosis, there are now alternate measures available, including ablations, surgical methods to deal with it so you're not exposed to hormones for the rest of your life. For those who are using it for contraceptive purposes, we tell them if you can, after a while, withdraw from the hormones and try to use condoms or barrier contraceptives, which are not hormonal, for some time before going back. So we're not saying don't use them, we're just saying keep a periodic pause between them when you're using them.
Thank you for answering that, doctor. The next lady here says that sometimes after strength training or chest workout, she feels pain around breast or chest bone area. How can she distinguish between normal muscle pain or something more serious?
So the pain that responds and settles with, say, a painkiller or with rest is more likely a muscle spasm. Breast pains tend to occur at the same time every month if it's breast-related pain. Exercise-related pain tends to be more the intercostal muscles and the pectorals of the chest wall rather than the breast, and they respond to just rest and relaxation, sometimes hot compresses.
Okay. Why is it, doctor, that mammogram is only recommended for people above 40 years of
Good
age?
question. So the breast is very dense. That's a nice question, actually. The breast is very dense when you're younger, and the mammograms may not penetrate enough. So there's no point using an imaging which is not going to give us any results. After 40 years of age, the breast texture tends to become fattier. The ovarian function goes down, the quality of the breast goes down. So the mammogram can penetrate better and see things better, which is why we recommend it after 40 years of age. The only time we add it, like I said, if you have a high risk history of in yourself or in your family, we added at 35 is to look for other changes in the breast in the form of calcifications. But by and large, less than 40 years, mammogram doesn't have a good enough yield. Ultrasound is a far better modality.
Great. Thanks for answering that, doctor. Does estrogen dominance and related health issues like endometriosis, for example, increase the risk of breast cancer?
So data on that is ambiguous at the moment. We like to say no. Having said that, we have sporadic case reports that giving any kind of hormonal therapy theoretically increases the risk in certain populations. Our issue is that those populations are not defined. So if in 100 ladies, 9 will have a problem and 91 won't have a problem, we don't know who those 9 are. So we tell them as far as possible, we try to restrict or limit or safely use those hormones on you. And we try to sort out the hormonal imbalances that are taking place for you, like endometriosis.
Thank you, doctor. The next question is if a female is trying to conceive through IVF treatment at the age of 33 or 34, is prone to capturing any breast related issues due to heavy dose of medicines, injections as part of IVF treatment?
Breast pain, tenderness, if she has underlying fibrocystic disease, fibroadenosis may increase. There are normally guidelines which are set up now, and the protocols are quite streamlined, even at these centers where IVF is done. I think they tend to give up to 3 cycles of IVF, and if they don't succeed, then there's a pause given before you go in for more. And we don't do any more than 6. So you go to a place which is a reputed institute. It is extremely expensive, of course, in this day and age to do it. See whether you have good yield of eggs before you go in for that. Have a conversation with the doctor about what combinations they're going to use for you and read up on the material. There's enough available reading material now. Drugs like clomiphene citrate, we know can cause things like that.
Thank you, doctor. There is a 3D thermography for breast cancer detection, which is being explored in research. Would you know when this would be available for patients?
I
Would you
think
be
we are
able to tell
still,
that?
we're going to have to wait. There's a little hype around it. We like to do that. We like to sensationalize topics now. Anything new is the new kid on the block. That's it. That's the man, the panacea of all evils. No, I think we have to be very, very careful and take this right now with a pinch of salt because there's a lot of ambiguous data coming in. So till we have, see, I'll tell you what happens. What works for one population base may not work for everybody else. You have to have trials across the world. You can't just do them in limited small places or populations with people who are there. So things may not apply to everyone else. At the moment, that is not recommended as a screening guideline. It's a nice gizmo to have. All of us, it's a nice thing to mention and talk about. But would I use that to make a diagnosis? No, not at all.
Mhm. Also, doctor, between mammogram and ultrasound, which is the best, quick, and more accurate
No,
screening?
they do different things. Mammogram picks up calcifications and architectural distortion. Ultrasound actually picks up the breast tissue, cyst, fibroadenosis, lymph nodes, blood vessels, shape, texture of the milk ducts, thickening, secretions. So they pick up different things. Mammogram can be done anywhere, and it's just an X-ray that has to be interpreted by the doctors when we see it. So the sonographer, the technicians do it. Ultrasound has to be done ideally by a breast radiologist. We normally don't like sonographers doing ultrasound because it's operator dependent. So we like to have our breast radiologists doing the ultrasound so they can see what's going on better. They complement each other. They're not mutually exclusive.
All right. The next lady wants to share that she is 25 years old. She does not have any family history of breast cancer and her periods are regular. When should she do a breast cancer screening?
So if she's absolutely fit and well, she starts doing it herself once a month. I think this is the age she can start. She needs to get herself checked for the first time when she's 30 years of age. And then perhaps once every 3 years till she's 40 and 40 annually.
Okay. Is
Assuming by
breast
that
cancer,
time, inshallah, sorry if I may interrupt, assuming by that time that there is no other comorbidity that's opened up, there's no hormonal imbalance, and she doesn't get to know about any other new family member with a cancer.
all right. Is breast cancer common in men?
Yes, it's not common, but we are seeing an increasing incidence recently.
If you don't undergo surgery and instead with chemotherapy until you're cancer free, is there a possibility of cancer returning higher compared to having an operation or
So let me put it
surgery?
this way, certain cancers need to be put to sleep before you remove them with the surgery, because during surgery they can spread. Certain cancers need to be removed first through surgery and tested to see if there is any benefit of giving them chemotherapy or not. For the breast, surgery is still needed. Unlike organs like the rectum, where if you have a cancer, we have a combination of chemoradiotherapy, which can cure certain types, not all, but certain types of those cancers. And we may not need to go in and physically remove the cancer. The breast is an organ which needs to have the cancer or the bed of the cancer or the mammoprint, as we call it, of the cancer, excised by itself. You can't leave it behind there. If I have a tree whose roots are weak, I can't say I have put pesticide on the tree, everything's going to be fine. I have to strengthen the roots to bear good fruit. The breast behaves like that. You have to deal with the cancer and remove that bed of the cancer or the cancer itself. The timing depends on what the type and the biology of the disease is. Is it before chemotherapy, after chemotherapy? Is it sandwiched between the chemotherapy and the immunotherapy? That's a call we take a little later. But yes, at the moment, we still need cancer surgeries.
Okay. Thank you, doctor, for answering that. Between ultrasound, MRI, and mammogram, which test should be done first? And if one test shows a negative result, should we proceed with the other one, the other two?
All right. My answer is going to be the same, girls. It doesn't matter how much you all bargain. I'm not changing my answer. Ultrasound and mammogram are the baseline test, darlings, which we need to do to see where we are with it. They complement each other. You can't do one and not do the other. Ideally, I would like an ultrasound first, mammogram as an add-on if the person is above 35 or is above 40, based on, like I said, high risk, no high risk, etc., etc. MRI is an extremely sensitive test. So it picks up everything which may not have relevance to you. You do an MRI and everything lights up like a Christmas tree, and what have I achieved? Nothing by doing it. So an MRI has to be focused to see what I needed to see if I needed to see something beyond an ultrasound and a mammogram. There's no one-stop shop, nothing that one size fits all. People need tests sometimes, ultrasound and mammogram, both most likely. Do we need to add something to that? Well, that depends on what they have.
Right. Thank you, doctor. The next one, this lady would like to know, is wearing a bra mandatory? I think that's all our dream. And what if we pass a week or more without wearing a bra due to some other medications or due to, weather conditions?
Okay.
Will it
Okay.
turn out to be a breast issue?
Nope, not that I see it happening. So long as you don't bang yourself or hit yourself, I'm okay with it.
I am just going to look for more questions in case we have.
I think there's a question related to you all. I saw it just now that at Majid Al Futem, Futem Clinic, where can you all test? I think you'll have to get in touch with your people. I'm sure you'll have a very good setup. Organize it.
Yes, can
Should you
you?
all go?
Yeah, sure. Sorry to interrupt, doctor.
So if you all would want to come to WellCare, you're very, very welcome. As I said, you'll have Sharanya's details. Get in touch with her and we'd be happy to see you all. Having said that, I think you'll have a good setup. You all don't need to come to us so early. You're welcome to coming in if and when there is a problem happening.
Thanks for answering that, doctor. And yes, you can always also get in touch with your HRs, and I'll be more than happy to connect you with Sharanya or Dr. Mahaara for any further queries or if you need to book in your appointments with her. We have few more questions here, doctor, in the Q&A tab. If I have Mirena, I'm sorry if I'm pronouncing it
Myrina,
wrong. I'm
yes,
not
correct. You're
Myrena
right.
loop, but I am 35 years old. Do I still need a mammogram or is it an ultrasound sufficient?
Do the
I think we are.
ultrasound and then we'll take that call. Do the ultrasound, get a clinical check, do the ultrasound, then let's take that call. Let's hold on to that. It's based on what we see.
Oh, 1 second. Yeah, finding lumps or painful at the right side of the breast to inner side of elbow. Is it just because of long hours of sitting in front of screen and mouse usage with the right hand, or it's related to breast cancer? Are there chances of breast cancer in future if we face such pain for long time?
It may not be related to the breast at all. Get yourself checked to see whether indeed it's related to the breast or whether you're developing a frozen shoulder and that nerve pain is radiating down to the chest wall. Pain doesn't have any correlation with developing a breast cancer later on. For those people who are looking for lesser hours at work, I'm sorry, I can't help you with that right now. We can't correlate it to the breast.
We have one more question coming in, doctor. Is it normal to feel soreness in the breast itself when taking off a bra after a long day, especially if it happens regularly?
I think the size of the bra is amiss, or perhaps the type of the bra you're wearing is not suiting you. So if you're wearing an underwired bra or a push-up bra, or you're wearing it on the tightest hook, or the size is not appropriate, then that's likely when you're having it. Otherwise, you should not have breast pain. The bra is meant to support the breast and comfort the breast, especially for large breasts which are saggy. So if you're having pain, look at whether you're wearing the right bra.
Great, doctor. I think with that, we have covered all the questions. And is there a, I know you've shared enough, but would you like to give a message before we sign off or a
I
tip?
think I don't think we need to be frightened with this hype around breast cancer. If anything, it is one of those diseases which is treatable now, it's curable now. Check yourselves. Check yourselves. It doesn't matter if you're a male or a female. Check yourselves. You'll be surprised how much you will get to know your own body that way. Identify what is going on because you're the best person to pick up if something new starts happening. Don't wait for that annual checkup or once in 2 years checkup where you'll go to a doctor and the doctor will see you and tell you, yes, something new is there. See yourself once every month. I think that'll be the best way to go forward. And thank you for having us here.
Thanks a lot, doctor. Like I said, it's always a pleasure to
The pleasure is
invite you,
mine.
and it was a great topic, great what do you call insights that you shared. And for all of you out there, thanks a lot for joining. Like I said, if you need to, if you feel like you need to speak to Dr. Mahara, or if you want to get in touch with her, please feel free to get in touch with Mediclinic Wellcare, if I'm right, Doctor.
Correct.
Mediclinic Wellcare, and you can always book in your appointments with her. Also, feel free to speak to your HR, and they can reach out to us, your insurance brokers, and I'll be happy to pass on your contact details with Sharanya for any further information that you require. Thanks a lot.
Thank you. Bye bye.
Thank you, Doctor.